Hello and welcome back. I'll be discussing the histopathological considerations and the diagnosis of interstitial nephritis today, and we'll be talking about an approach to this will be part 4 of this will be part 5.1 in an approach to peripheral edema. So I'll be approaching the topic in under the following headings. First, we'll try to understand the normal architecture of the renal interstitium under light microscopy, develop a systematic approach to the evaluation of the renal biopsy and why a primary glomerular or vascular disorder must first be excluded before we diagnose interstitial nephritis. Then we'll try to differentiate between acute interstitial nephritis and acute tubular necrosis, by which I mean intrinsic renal changes secondary to prolonged pre-renal acute kidney injury. Then we'll try to understand how sometimes, although this is uncommon, biopsy findings in interstitial nephritis can point to very specific etiological entities as a possible cause of the nephritis. And finally, we'll understand what constitutes chronic interstitial nephritis on histology, and that'll be the end of the discussion. So, uh, jumping right into it. So this first, before we talk about the interstitium, or rather how to approach the pathologies of the renal interstitium on a biopsy specimen, we need to first understand what are we seeing when we look at the biopsy. So this schematic that I've drawn on the right of your screen, that is actually a single linear core biopsy seen at low powers. And what you can see is what is clearly visible are the glomeruli. So these are the glomeruli. Obviously, these are highly stylized and idealized. This is similar to, but not exactly what you see under the microscope. Um, Along with that, we have some other things. So we'll just shade out the glomeruli. And once you shaded out the glomeruli, we find that there are a lot of circular structures within the interstitium of the kidney, and they are obviously the renal tubules. And although I've used a different what would I say, a different schematic for the entire nephron. Once you take two time cut section through those nephrons, obviously the tubules of different nephrons get cut at different levels. So as a result, you get a mishmash or a hodgepodge of these different types of tubular cut sections when you look at it under the microscope. So let's identify the tubular structures. So as this tubular structure is obviously arising from the glomerulus itself, it's likely the proximal convoluted tubule. And another characteristic feature is that the apical membranes of the cells here have a characteristic brush border. Okay, it looks like the bristles of a brush. Okay, those are the apical pseudopodia that are being extended upwards into the lumen, and obviously that increases the surface and area of the entire apical surface of the proximal convoluted tubule, because the proximal convoluted tubule primarily functions to reabsorb sodium, amino acids, glucose. So because of that, it requires a large surface area in order to function properly, and that is how it is achieved. Now, the second tubule that you can see next to it is also a proximal convoluted tubule. Okay, and this tubule on the right. So I'll just highlight all the proximal convoluted tubules that are visible in this section. Okay, so these are the proximal convoluted tubules. As you can see, they are all a little staggered. Now, once we get those out of the way, the next thing that we see are there are other tubular structures, but they are very lined by very thin epithelial cells. So they are almost flattened epithelium. Okay. And this flattened epithelium obviously performs part of the loop of Henle. This is either the thin descending or ascending loop of Henle. Rather, this is the thin loop of Henle. This is important. Okay. Now, we'll just highlight all the loops of Henle here. So, as is quite obvious, these are the loops of Henle. And okay, as we go more into the medulla, you would find more of them. Uh, obviously this is a highly stylized schematic. So drawn quite a few of them in the diagram. But again, the more medullary a sample, the more numbers of loops of Henle you'd find. This is not normally representative of what you find in a cortical normal renal biopsy. Okay. Now, moving on, the third type of tubule that you find is this tubule with columnar cells but without a brush border. Okay, so this represents the distal convoluted tubule or the collecting tubule. Okay, and we can just essentially highlight all of these structures within the interstitium, and you can see that there's a slight variation in the size of the tubules. It depends on where the cut section is taken. If it is a little bit more proximal, the tubules are thinner. If it is more distal, the tubules are thicker. So that's about it. So these are the structures that you see. In addition to that, we have some other structures. Those are the blood vessels that are within the interstitium. So now the blood vessels themselves are enmeshed within this what is the true renal interstitium, what I've highlighted here with this yellow highlighting what I've tried to highlight is actually the renal interstitium with blood vessels enmeshed within it. So this is the interstitium of the kidney. Now the thing is that this is what you see under the microscope, or at least this is what you expect to see under the microscope. What you actually see under the microscope is slightly different, not very different, but slightly different, and we'll come to it. Okay. So this is what we actually see. Okay. So what do we find? We have a step-by-step approach to evaluating renal interstitium, the pathology of the renal interstitium. So obviously this will be labeled as a renal biopsy. So then you know that it is a renal biopsy. So what we do is in step one we identify the tubules. So these are the tubular structures that are there. I know these are tubules because there are columnar cells within the lining the walls, and those columnar cells within them have a certain space. In some cases the space is actually obliterated, as is the case here, by some other cells, but in other cases the space is open. Now after that, the second step is to assess the interstitium. So once I know these are the tubules, everything outside of the tubules is obviously the interstitium. The third step is to assess the tubular lumen. Now, briefly, in the second step, you can see that there is that, see the interstitium that I had drawn in the schematic, that was very, that did not have a lot of cells. It essentially just had collagenous structure and some blood vessels enmeshed within it. Uh, the this brisk cellular infiltrate that you find here is not something that is normal. Okay, so there are a lot of cells in this area, and these cells they appear to have different nuclear morphologies. Some of them have dense chromatin, some of them have open chromatin, some of them have some of them have a polylobated nucleus, right? So they're neutrophils. Some of them have cytoplasms that are extremely that are red to orange in color. Okay, so these cells obviously represent your eosinophils. This is a very good example of an eosinophil here right here. So there is a brisk cellular infiltrate composed of acute inflammatory cells, some of them being neutrophils, like these cells that I'm highlighting as of now, and uh, some of them being eosinophils as these cells. These are the cells that are the eosinophils. So obviously this represents acute interstitial nephritis. Okay. So the diagnosis would be acute interstitial nephritis. But see, an important point is that it is acute interstitial nephritis only and only if the other compartments of the kidney are spared. Okay, and otherwise, yeah, it is interstitial nephritis, but the primary process is still glomerular. The primary process is may still be vascular. So, to define the diagnosis for the heading of the diagnosis to be interstitial nephritis, you essentially have to have normal glomeruli and a normal microvascular system on histology. And this is something that is quite intuitive because we've discussed how glomerular damage results in secondary tubular damage and because of prolonged proteinuria, and that can result in immune activation, and that results in an interstitial infiltrate and eventual interstitial fibrosis and tubular atrophy, which is what we call progressing to CKD. Okay, so now, the second diagnostic consideration that comes to the fore when you have suspected interstitial nephritis or acute interstitial nephritis is the differentiation of acute interstitial nephritis from acute tubular necrosis. So, as we've discussed, renal hypoperfusion when prolonged leads to tubular damage. Okay, so we've discussed that whenever there is a reduction in renal blood flow, that decreases the partial pressure of oxygen within the renal medulla. The renal medulla is obviously receives only 1% of the blood supply to the kidney, so the partial pressure is as such on the lower side. That ends up causing both tubular ischemia and microvascular ischemia, and these are the sequelae of microvascular ischemia. These sequelae essentially result in increased vasoconstriction and decreased vasodilation within the renal medulla, resulting in obviously further fall in the the blood flow to the medulla and further reduction in the partial pressure of oxygen within the medulla. And because of that, eventually there is structural damage to the endothelial cells and smooth muscles lining the blood vessels, and eventual endothelial obstruction, further exacerbating the decreased renal blood flow to the medulla. So, and then we saw how tubular changes occur because of this ischemia. These tubular changes are what actually we'll see in the next slide. There is, because of ischemia, there is the damage to the cytoskeleton of the columnar cells that normally line the epithelium, loss of planar cell polarity, that is the differentiation of the apical versus the basolateral membranes of these columnar cells, and eventually there may be full-fledged apoptosis or necrosis. So this eventually leads to a desquamation or of those cells of the tubular lining cells, which then fall into the tubular lumen, causing tubular obstruction. That increases that causes back pressure into the Bowman space, and that eventually worsens the renal function further. Okay, so this is essentially, the thing is that this can recapitulate the morphological findings that I've just described for acute intestinal nephritis, and so it becomes very difficult for someone who's looking at the histopathology, especially without clinical data to corroborate, but even sometimes in the presence of clinical data, because sometimes you have a patient who has primarily been admitted with, pre-renal acute kidney injury, which has become intrinsic renal failure, and then the patient receives a drug that may be responsible for causing interstitial nephritis, and then there's a serial rise in the serum creatinine. There's a reasonably common occurrence in the evaluation of critically ill patients. So in that situation, it becomes quite difficult to differentiate between drug-induced acute kidney injury, intestinal nephritis, versus worsening of the underlying causes of renal failure, or maybe say septic AKI being a super added cause of acute kidney injury. So this causes diagnostic confusion, and that diagnostic confusion is something that can be alleviated with a slight, by paying a little bit of attention to the details of the histopath. So basically, this is how you differentiate between acute kidney injury and prolonged acute kidney injury resulting in intrinsic renal failure and acute interstitial nephritis. So see, acute interstitial nephritis is it may be an outside-in process, as in the interstitium is affected first and the tubules are affected second. So the interstitial involvement is more likely to be much more prominent. Okay, there will be a lot of interstitial edema, a lot of very dense interstitial inflammatory infiltrate. However, the epithelial changes within the tubules may be very minimal. So necrosis may be absent. Uh, there may be minimal to absent epithelial desquamation or loss of planar cell polarity. Um, And if present, they often correlate with the degree of interstitial edema and inflammation. So the more the inflammation in the interstitium, the more the tubular changes. Okay, and the tubular changes often follow the interstitial edema. Okay, so where you have interstitial edema, you have tubular changes. In other areas, you don't. And when you look at the casts are epithelial cell only, but there are no hyaline casts, because hyaline casts obviously form when there is dehydration of the tubular contents. In case of acute kidney injury, what we with prolonged acute with prolonged ischemia, we then term it acute tubular necrosis. Now, the acute kidney injury, the interstitial changes may not be very prominent, and if they are prominent, they are associated with necrosis, as in there is a complete loss of the morphological findings of the cells within the interstitium, and they have a prominent eosinophilic nature, and you can't really differentiate between the cells. So in that case, the histopathologist is likely to then term the case as a case of acute tubular necrosis. Of importance, clinically, often this term of acute tubular necrosis is used, especially when trying to differentiate cases of other types of renal injury from prolonged renal ischemia resulting in acute tubular necrosis on histopath, or what is suspected as such. However, I don't think that's a very appropriate thing to do. So you could say likely leading to acute tubular necrosis, but to label it as acute tubular necrosis is, I feel, a little going fit further than the data leads us in a case. So being a little presumptuous, and you're also in the process ignoring other possible causes of renal dysfunction, okay, or renal injury. So this term is best I kept as a histopathological term, rather than being used interchangeably in clinical practice. Again, people go a step further and say acute cortical necrosis, and that to me is absurd. But okay, so there is no clinical uh, you know uh, avenue for the diagnosis of acute tubular necrosis or acute cortical necrosis in the absence of histopathology. So, essentially, if you label it as such, you obviate the need for further histopathological analysis. So, you essentially shut down the conversation. So, I would not suggest that you go down that line. It is best to refer to a patient with worsening azotemia or decreasing urine output as acute kidney injury or acute kidney disease, or if it's been more than 3 months, chronic kidney disease or acute on chronic kidney disease. So the reason for the labels is to, you know, uh, result in people actually talking about what may be the cause. Okay, so the diagnostic consideration of cause is the reason why these labels are given. So once you call it acute tubular necrosis, you're essentially labeling it as there is prolonged renal ischemia and nothing else, and that is not really representative of what might actually be happening, and that would not be a prudent way of approaching the problem. Okay, so coming back to this, in acute kidney injury, we have very prominent epithelial changes, and these usually occur very early. Along with that, you may have apical bleb formation. The blebbing is because obviously the cytoskeleton is maintained through ATP, and ATP are going to get depleted if you have prolonged renal ischemia. So as a result, there's apical bleb formation. Um, and epithelial cell desquamation usually correlates with the extent of other necrotic changes. This is quite self-explanatory, because both the epithelial cell desquamation is a type of necrosis of the epithelial cells, and necrosis of the interstitium is also a necrosis of the interstitium. And both are obviously the result of prolonged ischemia. So they correlate in severity and distribution with the epithelial cell desquamation. The casts are usually either hyaline. I use almost always hyaline. They may be epithelial casts, but there will definitely be hyaline casts, because there is pre-renal AKI as a proximate cause of the disease. So you will have uh, contents within the tubules that have gotten extremely dehydrated and coagulated, and they're forming hyaline cast. Okay, so this is our correlation between the schematic that I had shown earlier and the normal renal histopathology. Now you can see this is the interstitium of the kidney on histopath. There is in this case interstitial infiltrate of neutrophils and lymphocytes. Okay. Now, in addition to that, you also have, and this is very important, hyaline casts. Okay, essentially casts without any cellular components within them, looking almost like a sheet of glass. Okay, again there's a hyaline cast here. This is a hyaline cast. So then hyaline cast. There are also epithelial casts. Okay, but there are prominent hyaline casts. So, and the other thing you can see is that there is a lot of tubular desquamation. This tubule is extremely dilated. The cells have lost their columnar nature. Similarly, this tubule has lost its the cells are no longer columnar. Essentially, all tubules are no longer columnar. And however, the interstitial infiltrate is rather sparse. So this is the interstitial infiltrate. These are the relatively sparse areas of interstitial infiltrate. You expect, if the interstitial infiltrate is the primary cause of the tubular injury, you don't expect this much tubular injury. So naturally, the diagnosis then would become, yeah. So in that situation, the diagnosis naturally will become your acute tubular necrosis. Okay. Now you also find, so these epithelial casts are obviously due to sloughing of the epithelial cells into the lumen of the tubule. So the diagnosis eventually becomes acute tubular necrosis. Okay. So this is a slightly higher power view in order where I'm trying to highlight the blibbing of the apical cytoplasm in these cells. So it's quite prominent, as you can see, that here the apical cytoplasm is not smooth nor is it blush border. You're actually losing uh, the the contours of the apical cytoplasm, and you get these blebs on top here. Okay, so that's very abnormal. It's also very prominent here. Okay, so again, this is highly suggestive of acute tubular necrosis. So this is loss of brush border. Likely, you can see a little bit of the brush border preserved here. Okay, how is it different from blebs? The blebs are much more amorphous and extend far more into the lumen of the tubules, whereas the brush border is essentially like bristles of on top of the cell, the apical margin of the cell. Okay, so this would be your blebbing, and this would be your, and what are, yeah, these are your normal brush border. So part of most of the tubule has lost its normal brush border epithelium. Okay, now moving on, there is a fibrinous cast or hyaline cast within the tubule. So again, this is acute tubular necrosis and is not acute interstitial nephritis. Okay, now on the other hand, and here what we have is, as I've highlighted in yellow, cells that have infiltrated into the tubule. Okay, so they are there within the tubules themselves. You've got inflammatory cells infiltrating. So this is a process that is on histopath called tubulitis. Here in the diagram on the left of the screen, you see some eosinophils infiltrating into the tubule. So this is the tubule, okay, and this is the eosinophil that is infiltrated into the wall of the tubule. Okay, so again, this is a case of tubulitis. Again, tubulitis in quotes because obviously I cannot infer a dynamic process such as inflammation on histopath. I can infer it, but I cannot demonstrate it. So we call it tubulitis on histopath. Either way, so this would indicate that it is interstitial nephritis rather than acute tubular necrosis. So if it is present in acute tubular necrosis, you expect very significant tubular damage. And as you can see here, actually the tubules are relatively spared. They're not, retained their columnar shape, and importantly, there are no hyaline casts. Okay, so this is lymphocytic tubulitis, and this is eosinophilic tubulitis. Eosinophilic tubulitis may indicate that it is due to a drug-induced problem. Okay, now moving to the third part of our discussion, there are some etiological entities that on histopath can be picked up in cases of interstitial nephritis. So, an example of this, as you can see in this in this particular diagram, I have added a very interesting structure, two interesting structures in the interstitium. These are granulomas. Okay, now see granulomata, as we'll be discussing in one of our discussions on immunology subsequently, can be sarcoidal or tubercular. And these granuloma are actually more tubercular because they have, you have your two-tone giant, your sorry, you have your Langerhans and giant cells, and Langerhans giant cells rather, and you have a relatively large number of lymphocytes with a dense deposition of collagen. They are very well formed. Okay, what you don't have is a central necrosis, but again, that is not always needed. Okay, um, in the histopath here, what I have tried to highlight with this arrow is actually a single giant cell with peripherally spaced nuclei. So there's a cell like this, and there are nuclei on the periphery like this. Okay, so that is what we call a Langerhans giant cell. There's similarly a granuloma that is formed here. Okay, it's relatively loosely formed. Here there is another granuloma. So this is what we call granulomatous interstitial nephritis. Okay, and yeah, that's a giant cell. Now, granulomatous interstitial nephritis, the causes are relatively limited. So, as we've discussed, that includes sarcoidosis, it includes granulomatous infections, which would include obviously tuberculosis and fungal infections, and it also includes less commonly other tuberculosis-like infections, your nocardiosis, for example. Um, However, it also includes your drug-induced interstitial nephritis, although less common. So if you have granulomatous interstitial nephritis, you need to consider the possibilities of sarcoidosis and tuberculosis, and they go higher up in the differential. So what do we have here? Here, what we find is there's a lot of interstitial deposition of collagen. Okay, that is the eosinophilic material that is there in the interstitium. The glomeruli are actually not normal per se. There's a little bit of a lobularity to the glomeruli, and there is an obsolescent glomerulus here. And so I would actually not just call this interstitial nephritis. This is more suggestive of a proliferative glomerulonephritis with some interstitial nephritis. However, what is more very prominent is the collagen deposition in the interstitium and the infiltration of the interstitium by these lymphocytic cells, which are not very clearly visible on the scanning the scanning view of the microscopy. But this is obviously, I am telling you that these are lymphocytes. So we'll take a higher power view of the histopath, and what we find again is actually that there is what we call storiform fibrosis. Okay, so there's a lot of collagen that has been deposited. There are myofibroblasts within the collagen, and you see some lymphoplasmacytic infiltrate, so lymphocytes and plasma cells infiltrating into the interstitium, and there here on this side there is a little bit of a obliterative thrombophlebitis. Okay, so again the name thrombophlebitis should be under quotes, but there is obliteration of the vessel, and there is a slight thrombus formation within the vessel, and there is some endothelial cell in proliferation. Okay, so the diagnosis therefore then becomes IgG4 related disease. Okay, and how do I know this? Because I have done IgG4 related disease staining. So on IgG staining, you can see that's the same histopath section shows some staining. This is to be expected because we had a lymphoplasmacytic infiltrate, so the plasma cells are likely to and the plasmablasts are likely to stain for IgG. But when we do an IgG4 stain, we find that the staining is very very strong. Okay, and so that is IgG4 related disease on interstitial causing interstitial nephritis. It can look very acute, it can look very chronic, it can have prominent glomerular changes. So the diagnosis is essentially based completely on IgG4 staining itself. Now, coming to the last part of our discussion, that is the chronic interstitial nephritis. Again, you can see that the interstitium here is very highly expanded. The glomeruli are not normal. They show a little bit of enhanced lobularity and are quite brisk. But you can see that there is a lot of dilation of the tubular lumens, and the lumens are not circular anymore. They are elongated like this, and there's a little bit of tubulitis formation. So there is a prominent interstitial process here. Now we'll just, enlarge one section of this of the histopath here and see what's going on. So in the enlarged view, what we find is we have these lymphocytic cells infiltrating into the interstitium. Okay, these are the lymphocytic cells, interstitial lymphocytic infiltrate. We also have a form of fibrosis around the epithelial line tubules. Okay, concentric fibrosis. Some of the tubules have been completely obliterated. So this kind of prominent collagen deposition, again to be confirmed by trichrome staining, would represent chronic interstitial nephritis if the glomeruli are normal. Again, this depends on the histopathologist and how he or she describes the histopath. But see, this glomerulus is relatively normal. This is also relatively normal. I would not call this normal, and this would definitely not be normal. So again, it depends on how they describe it, but there is the interstitium shows features of chronic interstitial nephritis. Okay. Now, what you see here are actually radiological images. So this is chronic interstitial nephritis due to lithium. And what are the images on the right of your screen? That is a coronal. This is a coronal image. It's actually a very interesting sequence. This is a coronal rapid acquisition and relaxation enhancement protocol, which is the image has been heavily T2 weighted. This is a protocol, this is a type of fast spin echo sequencing, which essentially minimizes the motion artifact that would result. So what you find is that obviously this represents your spinal column and the fluid within the spinal column. This being a T2 weighted image that is white, and these are the two kidneys. Now, very importantly, within the kidneys, what you find are multiple small, discrete cysts, and these cysts are obviously full of fluid, and that is why they're T2. They show an increased intensity on T2 imaging, T2 weighted imaging. And on the left of your screen, what we have is an axial image, which has been again T2 weighted with some fat suppression. So this is fat suppressed because the fat and subcutaneous fat is completely suppressed, not very well suppressed here, but yeah, essentially quite reasonably well suppressed. And what you find again in the kidneys here, these are the two kidneys, are these small cysts. So as we've discussed, lithium enters your cortical tubule epithelial cells via the apical sodium channels, the ENaC channels, and then goes and inhibits your GCSK3 beta, the kinase. So that changes the cytoskeletal, structuring of the tubular epithelial cell in the cortical tubule, and those cells then lose their planar cell polarity, and essentially that eventually results in tubular dilatation and the formation of these cystic changes within the kidney. So as you can see, the cysts here are all very small, and they may even be visible on imaging. Okay, so this can even be picked up on ultrasound, and often a good radiologist will do that. However, again, we've discussed lithium as a cause of renal damage in multiple situations. We've discussed it in membranous G, and we've discussed it as a cause of FSGS. We've discussed it as as causing tubular injury. So, and it being a drug, it can cause interstitial nephritis. So, uh, see, sometimes when you have a patient with suspected lithium related renal dysfunction, it still requires a biopsy, even if the imaging is showing these cystic changes. Again, some data suggests that these cystic changes only occur in about 14% of the cases. So, it's specific, it's not highly sensitive. So it's something that you need to take into account while considering lithium related chronic interstitial nephritis. And the biopsy, as expected, shows the expected dilatation of the collecting tubules, and that is what you are seeing as those cysts on imaging. Okay, so that brings us to the end of our discussion. We've discussed the normal architecture of the renal interstitium on light microscopy. We've developed a systematic approach to evaluation of the renal biopsy. Again, first look at the glomeruli and the vasculature, then go to the interstitium. And again, in order to rule out primary glomerular and vascular disorders, we've learned to differentiate between your acute interstitial nephritis and acute tubular necrosis, essentially by applying the concept that in interstitial nephritis it's an outside in process, whereas in acute tubular necrosis both the tubules and the interstitium are being affected simultaneously. Um, Now we've also understood how sometimes, although not commonly, biopsy findings can point to a specific etiological diagnosis. For example, granulomatous interstitial nephritis, and as we've just discussed, lithium-induced acute tubular or acute lithium-induced tubular injury. Of note, when you have calcineurin inhibitor-related nephritis, often, as I discussed in in our talk on the mechanisms and pathogenesis and clinical features of interstitial nephritis. Calcineurin induced interstitial nephritis often shows a patchy involvement of the interstitium. So there are areas of fibrosis, then there are normal areas, then there are areas of fibrosis, and that is something, although uncommon, if present, again points towards a clear etiology. Then he finally understood what it means to call something to label a biopsy as chronic interstitial nephritis on histology, and what are the implications of the same. So that brings us to the end of this discussion. um, uh, subs- I'll be discussing the causes of increased right atrial pressure resulting in peripheral edema after a little bit of a delay, because I want to shift track and maybe discuss gastrointestinal symptomatology, and start our discussions on clinical immunology. That is basic immunological mechanisms, and build that up into how that leads to a deeper understanding of hematological malignancies and their clinical features, as well as infections, and then eventually it leads to the deeper understanding of how systemic autoimmune rheumatic diseases develop. So I'll see you then. Thank you for watching.